is, next slide please, Steve Wanklin, who's the lead pharmacist for palliative care, and the electronic prescribing pharmacist Connor Sharrock, and Erin Povey, who's the electronic prescribing system matron. So Guy's and St Thomas is a large, acute, integrated trust. We've had electronic prescribing for about 7 years, and we also have electronic noting and electronic lab results. So what we're hoping to describe to you today is the introduction of electronic systems to improve the safe use of oral opioids and also opiate patches. And those will be both on the electronic prescribing system and on electronic noting. Next slide. So we had a number of errors with the opiate patches and with oral formulations of opiates. We had patients who didn't have the opiate patch removed when a new patch was applied, leading to duplicate or even triplicate patches on the patient and opiate excess. We had confusion as to the frequency of applying patches. We had a lot of confusion about modified release versus immediate release oral formulations. We also had confusion between Oromorph and oxycodone because they both begin with O and they're both in the CD cupboard, but one is twice as potent as the other. Generally, brand prescribing of opiates was confusing because there are many different products, many different brands. The brand prescribing doesn't inform the pharmacology of the drug that's in the product, and we also had an issue where if we were to stock all the formulations available on the market, that would increase the range of products we had to hold and the cost. Next slide. So we sought to improve the safe use of opioids by implementing solutions in our electronic prescribing systems and electronic noting. Next slide. So we had an existing multidisciplinary opiate safety group, and we had worked with them to identify reasons for opiate errors. They then developed a paper solution which was really quite effective and successful in reducing errors. However, we moved to electronic prescribing. So then we had to test and configure electronic systems to document electronically the use of oral opiates and opiate patches. But the lovely thing was that we also managed to block unwanted practice. We also added hyperlinks to clinical information when it was needed, so you could click at the top of the screen and see information about converting between opiates or what was the release characteristic of opiate patches. Obviously, then we had to do user testing and put it into the live system. So next slide, please. When we examined the causes of errors with opiates, we found that staff weren't aware that the patient was on an opiate patch, or they forgot to add an opiate patch when a newer patch was applied to the patient. They might have been applying an opiate patch, but they didn't find the old patch on the patient because some of them are translucent and are difficult to see. We found errors with the wrong frequency of administration and confusion between brand names, and certainly plenty of confusion between immediate release and prolonged release. When we examined the causes of those errors using traditional medicine safety approaches, we found that patch application, unlike oral formulations, require 2 steps: taking off the patch and putting the new one on. And patches are difficult to see. Patches have non-daily application for many of them, so it's difficult to keep track of when the new one is due. In addition, patch formulation is not perceived as a potent drug, so people didn't necessarily take the fact that it was a patch seriously as they might have taken if they were giving an oral opiate formulation. I've touched on the multiplicity of opiates, strengths, forms, durations, frequency of patches, the release characteristics, and that all led to unfamiliarity with the multiple products and the multiple brand names. And the final cause of errors that we identified was that immediate release oral formulations were not labelled as such. Next slide. So this just illustrates the tablets of opiate tablets. So you can see Sevidol 10 mg tablets immediate release are not labelled as such, whereas 10 mg controlled release are labelled as controlled release, and similarly tramadol, though we hardly use that anymore, is not labelled as immediate release, but tramadol prolonged release is labelled as such. And you can also see that for the morphine product in top right is called controlled relief, and the tramadol product bottom right is called prolonged release. So multiplicity of terms. Next slide. So there's a technique called barrier analysis of possible solutions, and the strongest approach is to use strong barriers which reduce their reliance on humans, and the weakest approach is at the bottom of the screen with least effective barriers that have a high level of human reliance. We sought to eliminate the risk by removing brand prescribing. We discussed briefly about not using opiate patches, but that was not a viable option. We substituted designing and generic prescribing, and an electronic barrier was to co-prescribe patch off with the patch, and formatting the oral opiates as generic brands. Another barrier that we were unable to implement would be robotic supply and barcode scanning, but we're not in a position to be doing that right now. In terms of reducing the risk, you do a hazardous task less often, so that would be reusing a patient's own oral controlled drug. And then, of course, is the last and most weak is the human checks. Next slide. So this is the new paper prescription documentation. It's included here as part of the methods that we used, and some organisations might still be on paper. So you can see here on the medication administration chart, it says clearly put the patch on for the first time you prescribe it, then an arrow to patch off, and immediate below it, so a few minutes past the off box is the on box, and then an arrow indicating that you are not to apply anymore and indicating that continuous drug release is happening over the period of that arrow. So that's the patches on off. And next slide, and we also had an opiate, so that was a medication administration chart or drug chart. This is the patch monitoring chart, where you have a picture of part of the patient's body where the patch is applied and some monitoring points to check that the patch is still in place and hasn't rubbed off in the bed or in the shower. And it also prompts to remove the old before remove the new. So that was our paper system. Then we moved it into electronic systems. Next slide. Next slide. So we have an electronic pain score. Sorry, that's slightly showing it over covering the title. So this is an electronic pain score, which is based on a validated validated pain tool, and it just you can see at a glance and track over time the patient's pain, where the pain is from, and it recommends administration of analgesia. Next slide. There's an e-noting. We translated the e-noting form into the paper form onto an electronic noting form. So you can see here that it documents the number of patches applied, the strength of the patch applied, and also when this strength is selected, notes that this patch strength is available offering different application frequencies. Please ensure that you've selected the correct strength. So it provides information at the point that it's needed for the nurse, and it documents the location of the patch. And it also shows here the latest pain score, so you can link between the two e-noting forms. Next slide. This is the prescription of on the electronic prescribing system. So at the top here is information. You can link out to this information that supports you doing the correct action. Then there are pre-built prescriptions. So you select fentanyl 100 micrograms patch, or fentanyl 12 micrograms patch, or fentanyl 25 microgram patch. So you select the one that you want, and then at the bottom of the screen it has an and, so it's happening automatically. The prescriber doesn't need to remember a patch off, and you set the time for patch off before the patch on. Next slide. For oral dose forms, and whether we spread that to other patches, drug releasing patches. For oral dose forms, next slide. Next slide. So this, sorry, keep with the slide. So this is the, I'm sorry, this is the, go back one. This is the prescription for where we've pushed to generic prescribing. So even for morphine liquid, we have specified that that's immediate release, and there's pre-formatted prescriptions. If you get the next step onwards when you're prescribing, you can click and edit this to increase the dose that you wish. It's defaulted the minimum frequency, so it makes it easy for the prescriber and easy for the nurse, and also has a dose cap in it. Similarly, you can see that morphine, the fourth one down, is morphine sulfate modified release capsules. It defaults to twice a day. It reminds you that it's that you can open the capsules if you wish for patients who have swallowing difficulties, you click into the prescription. So rather than having morphine sulfate modified release at all the different strengths that you could have, you just select the tablet or the capsule and then click the prescription at the next step of prescribing to select the dose that you want. So all of that makes it easier for the nurse to see whether they've got immediate release or controlled release, and easier for the prescriber to select the dose frequency that accompanies the release characteristics. And the final third point is that it's generic only, because there's little evidence of clinical difference between the brands. Next slide. So that's the next step in the prescribing, and you just, at this point, you click in the dose and select the dose that you would like. This at the bottom of the screen shows for the nurse that it's a long-acting preparation taken by mouth every 12 hours. Just reminds them that they want the long-acting one. When they're in the controlled drug cabinet, helps them select the right one. Next slide. And the final thing that we're very pleased with is that the users are guided to use safer prescriptions. So if the prescriber tries to prescribe from scratch or tries to prescribe an immediate or modified release item, it guides them to the pre-formatted prescriptions, and that ensures that the nursing advice always appears. So here you can see that they've selected by generic oxycodone, and it says you may not prescribe, and modified release oxycodone, but they may not prescribe it. Next slide. You can see here that they've tried to prescribe Oromorph brand, and it's immediately taken them to the generic prescription. So it hasn't bumped them back, but it has just taken them from the branded item to the generic item. Next slide. So by way of summary, we have developed systems that first we developed them on paper to reduce the risk of errors with opiate patches and oral dose forms of opiates, and then we implemented those into our electronic prescribing and electronic noting systems, and that had the benefit of having less reliance on memory. That modified release tablets, for example, are twice daily. It supports information to patients because it pulls through to the discharge letter. Those generic prescriptions pull through to the discharge letter. In terms of assessing the impact, we haven't seen a reduction in the number of incidents reported relating to patches. However, the amount of harm in those incidents reported is lower. So it may be that having highlighted this risk with opiate patches, the awareness may increase reporting of deviations from procedure rather than actual errors. And we've definitely seen fewer immediate release, modified release opiate errors. The other thing is we've seen a culture change. So where people didn't necessarily where staff didn't necessarily take patches seriously, they now treat them with more care. So in summary, we have generic prescribing of our opiates because there was little evidence of a difference between the brands. We've built in patch off before patch on to structure steps in medicines administration. We've highlighted tablet release characteristics where that information wasn't on the packet already, and we've guided users towards safer practice. I would highlight that ePrescribing and eNoting are not integrated at the moment. They're two standalone systems, but we are integrating those into our incoming ePrescribing electronic health record. Thank you very much.
Hi Alice, thank you for your presentation. It was really informative. So there's been a few questions in the chat box. So one of the questions is your electronic prescribing system. Is it bespoke or is it commercially available electronic prescribing system?
It's a commercially available
system. Did you use?
It's called MedChart.
MedChart.
Yeah, MedChart.
Okay. Okay. And there's some questions in about with regards to patches, I think that's covered, but talking about syringe drivers and whether syringe drivers are covered by MedChart and how do you overcome the problems?
Yeah, syringe drivers and the combination, the admixture is quite hard to document. So they are not currently on MedChart. What we have is a placeholder prescription that's called syringe pump for palliative care. And that is prescribed electronically, and then there's an accompanying paper chart for which links with that. All the as-needed therapy for palliative care can be prescribed on the electronic prescribing system, but what we were able to demonstrate on the electronic prescribing system wasn't quite suitable for what palliative care teams wanted.
And is there,
can I ask a question?
Yes.
Seeing as I'm just two things. One thing, just to all the people who are asking questions in the boxes, if Alice can't get to them to answer them, we will pull them all together and send them to Alice and see if we can get her to answer them after the meeting. I just had one question, which I think is the same as Neil Poole has put in. It's about MXL and those 24-hour morphine sulfates compared to the 12-hour ones. I don't know how that was covered in your system.
So those are built in, and they're labelled as clearly labelled with the release characteristics of the product.
So on your drop-down list, they'll say morphine sulfate once a day or morphine sulfate 24-hour.
Yeah. And then so with the accompanying dose frequency pre-built, so that prescribers don't get that wrong.
Lovely. Thank you, Steph. Sorry for interrupting.
Oh, that's great. Thank you, Graham. I think that will be it for questions because I know we've got a packed agenda. Thank you, Alice. So I'll introduce our next speakers. So we've got Sue Parkinson, lead pharmacist for medication safety, and Marianne Taylor, lead pharmacist for electronic prescribing at Leeds Teaching Hospital, who will present on EPMA and medication safety.
Hi, Steph. Thank you for introducing us. I'm Marianne. I'm going to start off with the first few slides, and then, well, Sue and I are going to alternate throughout. So, if I just
Sue, if I get you to put your camera on for me, please.
What do you want on?
Your camera.
Oh yeah, sorry. We were trying to be discreet. So hi, I'm Marianne, and Sue is here. Hi. So we're trying to be COVID safe. Okay, so if you could move on the slides, please. Thank you. So at Leeds Teaching Hospitals, our EPMA system, which we refer to as EMEDS, was implemented between 2015 and 2018, and now is used in all adult and paediatric inpatient areas. So that's about, well, over 2,000 beds. And while we do still have some supplementary paper charts, very similar to the situation that Alice advised in St Thomas's, we do have intentions to extend further. Whilst we do have some charts and we're looking to extend into complex infusions, we consider the system to be embedded within inpatient areas. So our focus is now on optimization. And as a large teaching hospital with a large pharmacy department, I mean, we recognise we're very fortunate to have a number of teams who work on medicine safety activities. So we have quite a collaborative approach between the medicine safety team, the eMeds team, we have representatives from our clinical pharmacy teams, and we also have an MMPS, a pharmacy nursing team, and we all worked collectively to introduce medicine safety improvements. So next slide, please.
So I was just going to talk a little bit about the governance structure that supports the flow of information within the Trust, and how we have worked in our eMeds and safety teams together. So from this slide, you can see that we have a quality and safety assurance group under which sits the LTH Medicine Safety Group. This is a multidisciplinary team. We have medics, some AHPs, nursing and pharmacy membership of that group. It has a number of subgroups, one of which is the Medicines Incident Review Group, and another of which is the Prescription Stationery Group. There are other groups as well. And just if I take the Medicines Incident Review Group, this group is responsible for reviewing all the medicines related incidents that happen in the Trust. This is done by a daily review of incidents by the medicine safety team, which is fed up into a weekly rapid review of anything of concern. At this point, we get the MMPS nursing team involved, and if necessary, we'll get the eMeds team involved at this point. But if not, then the eMeds team sits on the Medicines Incident Review Group. And then we also have the Prescription Stationery Group, which is historical really, in that from when we had all paper charts, and our main aim moving forwards is to remove as many paper charts as possible and really push as much as absolutely possible onto eMeds. So the charts originate from the clinical pharmacy teams, which are then reviewed through the medicine safety team and fed into the Prescription Stationery Group. And we've incorporated the eMeds team, in addition to the other multidisciplinary members of the team, onto that Prescription Stationery Group. And what we're looking at the moment is how we can interact those and really link those two groups together. So we've got two-way flow of information between the Medicines Incident Review Group and the Prescription Stationery Group, particularly in relation to eMeds. Next slide, please.
Okay, so I'll just talk a bit about how things have changed since we implemented EPMA. So, I mean, you'll be aware that the literature shows that the biggest gains in safety tend to come at the point of EPMA system implementation, and that's just at the point of implementation, and that's largely due to improvements in allergy awareness and because the prescriptions are legible and complete. And then further gains in medicine safety are much harder won, because they require an understanding of the wider environment, insight into the impact of clinical decision support, and improvements must work around any system limitations. So in our case, some of the trends that we've seen relate to the fact that the EPMA system has much better data. People can see the times at which medicines are given. So we think that it's highlighting issues that have always been there, but are much easier to see. So, for example, doses given too close together. We've got issues around failed EPMA barriers. So that might be from duplicate prescribing or excess dose errors where the alerts are ignored or missed or misinterpreted. We've got risks from dual paper and electronic system use. For example, the transition of paracetamol overdose patients through A&E into the inpatient beds, and how the acetylcysteine infusion program works from paper prescription started in A&E through to potential inpatient use on EPMA. And there is also issues around the interplay between digital systems. So with misunderstandings about what information flows between our systems. So from an EPMA point of view, we're now dealing with risks from alert fatigue, from digital system rigidity, and expectations of safety and interoperability that just aren't met. And so it adds another layer of complexity on top of our traditional approach, looking at mitigating drug-based trends in medication safety. Next slide, please. And actually quite a lot has stayed the same. So you'll be familiar with all of these categories of incidents. We still get incidents with anticoagulants, with insulin, and just as Alice has described, between opiates and MR and plane preparations. And despite the fact that in our EPMA system, there is a requirement to confirm the patient at the point that the medicines are administered, we still also have patient ID errors as well. Next slide, please. I thought you might be interested to have a look at some of our data. So forgive the very sort of busy screen, but the graphs show incident numbers from Datix alongside the change in EPMA system use. And we used the number of doses administered, which is the bold black line on the slides, as our proxy for EPMA use. So you'll see we started in 2015, 2016, and the numbers of doses administered have climbed during our implementation. So the left axis shows the number of doses recorded on EPMA, which is between 2.5 and 3 million per quarter. And the right axis is the number of incidents represented by the coloured lines. So the top graph, we've got all medicine-related incidents, which is that red line. Those are, all medicine-related incidents in the top graph. And the lower graph shows the incidents by category. So we've pulled out the administration, which are the green ones, the prescribing are the amber colours, and then the red line in the bottom graph is what we call EMEDS, medicines related incidents, which are simply those that mention EMEDS in the text. So as you can see, it's rather a blunt instrument, but it is our way of picking up EMEDS incidents. And then the small graph squashed into the bottom right shows the correlation between EMEDS doses and EMEDS medicine-related incidents, because there's quite a strong correlation there. But I think it's fair to say that the only thing we can say with certainty is that EPMA implementation doesn't magically reduce medication incidents, and the COVID pandemic caused a marked reduction in activity at the beginning of 2020. Next slide, please. So just to talk a bit about our medicine safety approach, we worked to a number of principles with an emphasis on improvement methodology. So one of the early challenges was ensuring that issues could be escalated when system knowledge and understanding wasn't widespread among decision makers. We've had to work on that, particularly in relation to our medicine safety groups. And the digital clinical safety strategy, which was released in September, I think that really describes our approach, thankfully, very well. So sort of a dual aim to promote the use of digital technologies to improve the safety of digital technology implementation in health and care, and to use those technologies to improve patient safety and in our strategy. Next slide, please. And I really like this quote from, I think the reference to it has just dropped off the bottom of the slide. So it's a quote out of Lean Hospitals, and we've taken this as another sort of foundation for our approach. So it was common for us to sit round a table looking at incidents and kind of speculate as to what might be the problem. And I think this illustrates how important it is that you go and find out what's actually happening. You do your root cause analysis. We're all very familiar with that, but you're looking to find out what probable causes are, and then one by one you work through those probable causes to see that they're actually being fixed by the solution you put in place. And so we've modified our approach to problem solving so that we go and see what's happening, analyse root causes, and check for impact using PDSA cycles. Next slide, please. So I'll hand over to Sue to go through our insulin prescribing incident.
Thanks, Marianne. Yeah, I've got a couple of examples to share with you where we've hopefully used the tools that Marianne has described to you and made some changes on EMEDS, or not, as the case may be. So this first incident will be, I'm sure, familiar to a lot of you. It was a patient who came onto the ward. He had a complicated history, including an ICU stay, and he was improving on the ward, but then found to be hyperkalemic. So following our trust guidelines, 10 units of Actrapid was prescribed appropriately as per the guidelines, and it was prescribed using the protocol that we currently have set up on eMeds. Junior nurse made up the insulin infusion. She was junior, that's quite key. She'd never made up an insulin infusion before, and she didn't recognise, unfortunately, the absolute need to use an insulin syringe, and I'm sure everybody will be familiar with this problem. Consequently, a 10 ml syringe was used, and the nurse actually added 10 ml of Actrapid to the syringe, which meant that 1,000 units of insulin was added to the syringe. The insulin was started. Fortunately, the sister on the ward recognised the error, and the infusion was actually stopped. Next slide, please. So obviously, this fulfilled the criteria for an error event, so an SI investigation was completed. I'd like to stress the findings are multifactorial, and I'm only going to concentrate on the finding relating to eMeds and how eMeds could help us. So we found that as part of the investigation, there was a lack of familiarity with using an insulin syringe. A lot has changed in administration of insulin over the last few years, I'm sure everyone's aware, and the junior nurse in question wasn't familiar with using an insulin syringe. There was a lack of anything directing use of an insulin syringe, and nothing with the vials of insulin to promote selection of a syringe. So with these and the other findings from the investigation, we thought, well, how could eMeds help? So we looked at the root cause and the actual problem, and the real problem was that the nurse in question, a junior nurse, forgot or didn't recognise that absolute need to use an insulin syringe. So the obvious answer is we want to tell the staff to use an insulin syringe. And as Alice, I think, really neatly showed with her pictorial representation of barriers in place, one of the stronger ones is to actually tell staff to use. You don't expect the staff to actually remember themselves. We thought, could we add this to the eMeds prescription? Next slide, please. So this is the new eMeds prescription, and as you can see, as well as having the dose, we also have the words using an insulin syringe. So this is on the how it appears on the drug selection screen, and the instructions do appear. Next slide, please. And this is it on the administration screen. So as you can see there, it actually appears twice. It appears under the dose that they'll be administering, it says the words using an insulin syringe, and then under the prescriber's instruction that the nurse has to tick to declare that they've completed it, it says using an insulin syringe. So this means that the reference to the insulin syringe appears on in a number of different times throughout the whole administration process. Next slide, please. So obviously, like I've said, I don't want you thinking that was our only action out of a serious incident investigation. We had other findings and actions to complete. But in relation to the eMeds thing, what we're going to do now is we're going to go out, have a look and see whether this is working. Has it made a difference? We're going to talk to some of our nursing colleagues, see how it's making them feel, and to check that they actually see it and are using it. So that was the example of an incident where we've managed to make a change in response to the findings. Next slide, please. So very quickly, because I know we're very short on time, I'm just going to whiz through this one, which was an example of vancomycin prescribing. It was a patient who had a loading dose of vancomycin followed by a maintenance dose. The doses prescribed were correct, but the maintenance dose was actually prescribed to start before the loading dose. There's complicated reasons to exactly how and why that happened, but the result was that she received 3 doses of vancomycin in 24 hours. So obviously, again, there were a number of different findings, and including that eMeds hadn't made it easy to do the right thing for either the nursing staff or the prescriber. So one of the actions that we were challenged with was to change the prescribing protocol to try and guide the prescriber and the nursing staff through the process. And this was in the same kind of way that it used to with our old paper prescription chart, which basically took the prescriber through the process, guided them through the prescribing, and then took the nurses through the administration process. Problem was that we found, because the vancomycin loading dose doesn't directly link to the maintenance dose, we would actually have been increasing our risk of error due to the number of slightly different regimes that would have been needed. So we would have had a big long list of different regimes that would have just been confusing. So we decided that at present it was safest to make no change at all at the moment. Obviously, we'll keep this under review as more updates for our eMeds come out. Next slide, please.
Okay, so last slide, really to finish up, EPMA systems do improve safety with medicines, but their limitations cause errors and can make improvement work difficult. So we have to make the best of what we've got and work closely with suppliers, but making the best of what we got really is really key. We are struggling with communication of medicines or EPMA risks. We have over 5,000 prescribers set up in our system and many more nursing staff. So how do you best communicate with bodies as big as that? That's has always been an issue, but is a concern for us. So that's why designing risks out of systems is really has to be a key focus. EPMA systems provide lots and lots of data, but we struggle to make the best use of that. And we need to optimize how we record system-related incidents as well in order to improve monitoring and insight. And that links again back to the digital clinical safety strategy. And finally, just that, you know, our approach is this small steps of improvement, which can feel like slow progress, but we believe that it produces better results. So thank you very much.
Hi, thank you both for your presentation. It was really informative, and it's good to see, as someone commented, Naomi Benter commented, that the problems seem to be the same problems in most trusts. It's not a unique problem, especially when it comes to medications such as anticoagulants, and as we've seen with the antibiotics, vancomycin and insulin. One of a question that I'm going to ask is, with the insulin incident and the way it's now described, is it DMD compliant, and will it be at all when you add in that instruction onto it?
Yeah. So our insulins aren't technically DMD compliant. We used an approach with the trust. So DMD, certainly the data we have, it's either a generic description or a brand description, and it doesn't link the generic and the brand names together. And we've gone down the road that we feel it's important that we make that link. So all of our insulins have been home built, if you like. The interesting thing about the infusion one is that all of our insulins also have the strength in, apart from insulin infusions, because that relates to another incident that we removed some information. And again, whether it's really had, I think it's arguable as to whether it's really had the impact that people were hoping for. But I think this question around DMD is really interesting, isn't it? It's going to be a big challenge to make that work within our environment, and even the idea of any kind of mapping process fills me with dread, because it's such a responsibility. So yeah, another big project coming, I think. Does that answer your question?
I think it kind of does, and yes, in a way it kind of does. And thank you, Sue. And I know we're running out of time, so any questions that were asked, I'll send them to you, and if you can, and we'll put them to everybody else with the answers at a later date. So I'll move on to our next speaker. Okay, so I'm going to, the next speaker is Jill Green, who is a specialist pharmacist in medication safety at the Royal University Teaching Hospital. And again, Jill, I'll hand over to you to present. Thank you.
Thanks, Steph. So I'm going to talk to you today about some safety initiatives that we've introduced to our EPMA system here at Wirral. So just so briefly, I've moved over to the med safety team very recently from informatics. So hopefully I'm going to be able to marry the two elements during this talk. And I'd just like to mention before we begin that I think a lot of these points have already been discussed in our previous talk, but although EPMA has many safety advantages, it can bring its own risks. However, not every development that we introduce needs to centre around big multidisciplinary projects, and smaller specific enhancements can have significant impact and safety benefits. And I'm just going to demo a couple of those that we've introduced at Wirral today. So next slide, please. So a bit of background, we've been using EPMA at WUF for quite some time. So since 1993, although we moved over to Cerner in 2014. So again, as per Sue and Marianne's talk, we're very much in the optimization stage of our using our system. So all inpatient areas across the trust are live. We do have dedicated informatics and medicine safety pharmacy teams in-house, and we are able to respond to the needs of the organisation, as well as linking in with a technical development team that are able to introduce more complex technical developments. So good working relationships between different teams is key, I think, really to make sure you're getting the best from your system. And I think we've learned and we demonstrate that communication is vital, as well as robust governance around decision making. So move on to the next slide, please. So a couple of the safety initiatives that I'm going to talk about today. A couple of alerts that we've introduced around anticoagulants and insulin high doses. So weekly methotrexate and prescribing of IV aminophylline. Next slide. So we're talking about co-prescription of anticoagulants. So incidents were reported in our organisation surrounding duplicate prescriptions for and hence administration of anticoagulants, whereby patients were receiving more than one anticoagulant inappropriately. So just to note, at our organisation, there is a functionality from Cerner that involves some interaction between drugs, but we don't use it here at Wirral. So next slide. So the solution that we introduced was a hard stop EKM rule, otherwise known as a pop-up alert, to prohibit prescribing of two anticoagulants concurrently. So as part of the workflow, the user will be informed that the intended order will be cancelled if a second anticoagulant is if a user attempts to prescribe a second anticoagulant whilst one is already prescribed. And this is at the point of adding to Scratchpad for any of you that want more technical details, and applied at the primary level. So it was a complicated specification involving prescribing of two different DOACs, or DOACs plus low molecular weight heparins, including enoxaparin and fondaparinux. And as you can imagine, this involved lots of testing. And various issues arose during the testing period. We just decided to exclude any drugs that could be given together. So warfarin and heparin were not included in the rule. So it only involves drugs that are always contraindicated when given together. It involves inpatient and discharge statuses for active orders. Therefore, if the first anticoagulant is suspended, a second anticoagulant may be prescribed and the rule won't fire. But if the suspended anticoagulant is resumed prior to the active anticoagulant being deleted, the alert will fire to prevent the two orders becoming active together. And it also allows for future prescribing as long as there's no overlap. The next slide, please. So here's a quick demo of the workflow. So as the user goes to select the drug and sign, they'll be presented with this alert telling them that they are unable to proceed. The only way forward is to cancel the order, and the user will then have to back out of the order that they're attempting to make. So next slide. So I've got a graph here of incidents that were reported over a time period, and although this is a duplicate drug or class of drugs data, and it's not specifically around anticoagulant or not presented at the level of anticoagulant detail, you can see that there's about a 25% reduction in incident reports since we introduced this alert back in 2018. So we haven't had any reported incidents when the alert is used as intended, although we did have one related to an inappropriate interval of time between the administration of a patient's usual DOAC prior to admission and then a subsequent low molecular weight heparin being prescribed, although I'm not sure that any electronic system would be able to address that risk, certainly at this point in time. And we also note the limitation around any miscellaneous drug that's prescribed. So if there are any low molecular weight heparins that we don't include in we haven't built out in our drug catalogue, for example, dalteparin, then of course the alert won't fire. So next slide. So moving on to our next issue, which was about insulin prescribing. So until the end of 2018, this was prescribed on paper, and it was decided to develop into an electronic solution. So there was an official project board created in order to do this. They reported some concerns prior to go live regarding an inadvertent overdose through adding extra numerical characters of inadvertent overdose of insulin when adding extra numerical characters when typing the dose, or confusion that the strength of the insulin device face up on the prescription could be misinterpreted as the dose. So if you move on to the next slide, thank you. So you can see here, this is a snapshot of our order screen. The 100 units in a mil strength of the insulin device would be visible face up on the prescription. So next slide. In order to combat this or to mitigate this risk, we decided to introduce a soft stop EKM alert this time to fire if more than 100 units were prescribed. So the user would be warned that this represented a high dose, and they would then be asked to continue, cancel, or return to review the order. So I should probably mention that although I've just talked you through two examples of alerts that we have here at Wirral, it's something as an organisation that we try not to rely on, and we avoid as much as possible because of the risk of alert fatigue. So if you move on to the next slide. So here you can see again the strength of the insulin device face up, but if a user went to type in the dose and added in an extra 0, for example, and it became over 100 units, they would be presented with this screen, as I said, listing the options of how to proceed. So we haven't had any incidents reported about the impact of this alert, but we have received anecdotal reports that it encourages increased consideration of the dose that is to be intended for the patient. It's quite difficult to report on in terms of extracting data from the system, because for some patients over 100 units could be a legitimate dose, and hence there would be an element of interpretation required. However, kind of indirectly, we did manage, by introducing electronic prescribing of insulin, we have enabled the trust to meet the national standards of insulin prescribing. Okay, moving on. So quickly talking about methotrexate. So this was built as a weekly frequency, but we did have an incident reported regarding 2 doses of methotrexate being administered in one week, which would be classed as a never event with overdose of methotrexate for non-cancer treatment. So it was identified as a limitation of our EPMA supplier that weekly frequencies generate an administration task for the following day by default, which has implications if the patient has already taken their dose that week prior to admission. So, for example, if a patient took their weekly dose on a Sunday, was admitted to hospital on a Monday, their methotrexate prescribed, the dose would schedule for Tuesday if the user didn't amend the start date of the prescription. Next slide. So in order to look into a solution, we managed to build out explicit days of the week frequencies, meaning that the dose schedules for the intended day. So, for example, weekly on a Monday, weekly on a Tuesday, etc. We would also hope that this encourages the prescriber to confirm the patient's regimen rather than just allowing for the dose to schedule for any day. So next slide. Might be a little bit small on your screens, but hopefully you can see here an example of our plan for methotrexate, whereby the days of the week are laid out, and the explicit date, this explicit day is included as part of the frequency, along with some of the options of the dose regimen there. And you'll be happy to know, as we are, that there were no incidents have been reported since this was introduced. So next slide. So the final thing I want to talk to you about is about intravenous aminophylline. So as we all know, IV aminophylline is dosed on body weight, and this was initially built out evoking our drug calculator as per the 5 milligram per kilogram or 500 microgram per kilogram per hour loading and maintenance doses. So another limitation of our ePMA system is that the dose calculator, when it is launched, accepts the patient's actual weight. So the weight that the actual weight when that's been added onto the system as the default dosing weight. This has implications if the patient is overweight or if an ideal body weight is required to dose, leading to the risk of high therapeutic levels and toxicity. And we had a couple of incidents reported surrounding dosing errors. We suspected that the proposed dose of the system, based on an actual body weight, was being accepted by prescribers, despite guidance in the plan advising the use of ideal body weight and being presented as a related result. For those of you that are unfamiliar with Cerner functionality or this term, it's essentially just some additional information at the point of prescribing that would help guide the prescriber to make a decision about that drug. So might include weight, a blood result such as INR or platelets. We also had some anecdotal reports that users were quite alarmed whenever they came across the dose calculator, as we didn't tend to use it for many drugs, and hence when they encountered the dose calculator, it was quite off-putting. So next slide, I'll just show you a screenshot of what the dose calculator looks like, which is, I guess, difficult to interpret out of context. But the target dose and the rounding and the top left of the screen, we would expect the user to leave those elements of the dose calculator. They would be specified at the point of drug build. But it would be this adjusted weight that we would want the prescriber to review and edit as necessary. You can see here the patient's weight measured of actual weight of 100 kilos has dragged through and is what the dose calculator was wanting to dose off. And then users are then through. So next slide.
Chair, I'm going to ask you to wrap up.
Yeah, I'm almost done now. So the solution was that we decided to remove the dose calculator, which potentially is a backward step in functionality, debatably, and we introduced weight banded dosing on ideal body weight in order to circumvent the need for the dose calculator. And we haven't had any incidents reported since. And I was going to say, if there's any questions, appreciate we might be out of time.
That's great. Thank you, Jo. Yes, I think we're out of time, so we have 1 minute left of the webinar, but thank you. Any questions that were in the chat, I will send them to you, and and we'll send them out to the delegates afterwards. And I just want to say thank you to all our presenters that we've had today, just bringing about the solutions, the electronic solutions to the medication safety issues and medication prescribing errors that we've been having. As you can see, electronic is a way, but it's not only the only solution. So there's lots of things that are involved when you're thinking about transformation and you're thinking about transforming prescriptions. And so it needs a collaborative approach between the medication safety officers and electronic prescribing informatics teams as well. I don't know what you think, Graham.
Yeah, I quite agree, and I was just going to finish by saying I think we should do this on a routine basis, getting e-prescribing experts with the meds safety experts together. So hopefully we'll do this again, maybe on a six monthly basis. So thank you to all the speakers and to all the attendees. Thank you very much.
Yes, and we'll see you next month for those who are part of the EPMA Masterclass, so 9th of March between 1 and 2. And if anybody would like to present a future topic and volunteer at future sessions, if you can email Sarah Black, her emails on the screen. And thank you all for attending. Bye now.
See you all.